This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
By pulling together a comprehensive digital solution, we can interact with the patients, tone it down or tone it up, because many of these patients have so many problems, you can't address them all at one time. So you have to individualize it for the patients. What does this do for the patients? It improves their recovery. It gives them access to their provider. It decreases their level of disability. It can decrease the readmissions.
Welcome to Sg2 Perspectives. I'm your host, Trevor DaRin. Today I have my colleague, Kate Zentner, who leads our neurosciences service line. And she looped in a fantastic member, Dr. Pam Duncan, who was formerly a professor of neurology, is currently a professor of internal medicine at Wake Forest Atrium. She's going to share the patient-centered tools that she's created and pioneered and that are making a great impact. And we're using it as an example. We don't often drill this deep into one solution, but we want to use it as an example of a big theme that we're pushing out at Sg2, the balance between scale and personalization. Kate, why don't you set up why this is such an impactful solution, why stroke has been such a challenge for health systems to manage, and why Dr. Pam's story is so impactful and what you want our members to hear from her today.
Absolutely, Trevor. I have been really looking forward to this conversation. And this is a topic that we've been weaving through a lot of our stories this year. If you joined us for our recent Sg2 Neurosciences Landscape webinar, you might have heard that we did also talk about that need to better orchestrate, better integrate care. Stroke is one of the important examples of that. Sg2 is projecting significant growth in stroke readmissions over the coming decade, but we're expecting even higher growth in patient days as a result of rising complexity. We see now that stroke mortality is on the rise, and unfortunately, it seems as though it's younger age groups that are experiencing worse trends compared to older adults. We're also seeing in our clinical database that we're still at right about 12% of ischemic strokes getting readmitted within 30 days. And they're having all kinds of issues spanning recurrent strokes to infections to CHF. And then even beyond that, there's this troublesome story looming where we have this rise in chronic diseases, whether it's hypertension or others that we know are major risk factors for stroke and all kinds of other issues. Unfortunately, stroke, it's a big population already, and we have some problems that we expect are going to get bigger. On the bright side, though, it's not all doom and gloom. We can say that we have seen some incredible strides made on the front end with acute interventions to minimize the damage to these patients early. And that does continue to be an exciting space, but these interventions are only going to be applicable to a minority of patients. All in all, there is this broader world of needs that we're going to have to be able to help patients meet, whether they get these advanced therapeutics that we talk about all the time or not. When we're talking to every member virtually across the country, where they tend to have the hardest time and struggle the most is what happens next post-stroke. That is exactly why we wanted to talk to Pam today. Pam's from Advocate Atrium Health, Wake Forest Baptist. And for anybody out there who's worked in neuro, you know her name for the award-winning work that she's done over the years to improve outcomes for stroke patients. Just to name drop, you may know her as having been the PI on the COMPASS study that examined transitional care and stroke. And she was the first woman to be awarded the David G. Sherman Lifetime Achievement Award from the American Stroke Association back in 2020. She's also the founder and CEO of Care Directions, which offers a digitally enabled solution aiming to enable transitional care. That's what I'm looking forward to learning about today. Thank you for joining us, Pam. We know that there have been a ton of challenges to adoption, but your work has shown us that better orchestration and personalization for stroke survivors, particularly in that critical, challenging transitional phase, it's possible to achieve if we have the right tools. Let's begin there because you've developed the tools. Tell us about stroke CP, its origins, and what impacts are possible to achieve if transitional care is done well.
Thanks, Kate, for that background. We do have a major health crisis in this country when it comes to management of stroke. There are over 795,000 strokes a year. Stroke mortality has decreased about 80% in the last few decades. However, stroke disability is increasing. With increased survival and also with younger strokes, we're seeing major trends in disability that can be managed more comprehensively through better health care and integrated health care. I have had a long career in the post-acute space. In 2011, I joined Wake Forest, and in 2014, I took advantage of Wake Forest's Learning Health System project, in which they demonstrated that if you followed patients immediately after their acute hospital stay, you could decrease readmissions significantly, 30 to 40%. And if you remember at that time in 2011, it was when they were rolling out all of the readmission penalties, whereas stroke wasn't one of the prime conditions. Everyone was focused on stroke readmissions. It was in that current environment of 2011 that we submitted a PCORI grant called the COMPASS study, Comprehensive Post-Acute Assessment. And it was in that study that we did focus groups with patients, caregivers, providers all across the state of North Carolina. This particular study was limited to 41 hospitals in the state of North Carolina. And we found, number one, that patients are very dissatisfied with their care once they're discharged from the hospital. In fact, I've used a quote that's so vivid to me every day from one of the stroke survivors in the focus groups. And he said, "I was life flighted in and I was parachuted out with a hole in the parachute." That problem existed in 2011. It's escalated today because in today's current healthcare environment, there's tremendous stress in the healthcare systems to discharge patients within 3 days. And in those 3 days, a small minority of patients have received those very successful acute interventions of TPA or thrombectomy. But even among those who have, they have residual deficits. We also found that in the COMPASS study, patients, and the patients enrolled in this study were those going directly home. We also found that 75% of them were on 5 or more medications. 36% had undetected cognitive deficits, and there was poor knowledge of risk factors for blood pressure control. At that point, we developed a model of transitional care. We took advantage of the CMS transitional care codes that were in place, and we also embraced their standards to be funded so that you would need to have a 2-day call after the stroke, be followed up within 7 to 14 days by an advanced nurse practitioner physician, and there needed to be a comprehensive assessment of the patient's social and functional determinants of health and ensure that they get follow-up appointments and they're referred to community-based resources. That was a big lift. We found that even then, and more so now, it's very difficult to capture this information quickly in a brief visit. So we developed a tool that was developed on a research platform. At that time, it was called COMPASS. We interviewed the patient and or the caregiver across all their social and functional determinants of health. And on this research-based tool, which we actually use SAS programming, we could immediately develop a care plan, prioritize the patient's needs, and link them to community-based resources. We brought to the transitional care visit the first automated assessment that immediately generated a care plan and also did a summary provider report so that when the patient saw the physician or advanced nurse practitioner, we prioritized what the problems were. We rolled that out in 41 health systems across the state of North Carolina. What we found is tremendous clinician satisfaction with this tool. And they said, by using this systematic automated approach, we're picking up things that were often overlooked. And one of the most common things was the patients were cognitively impaired. They had new onset cognitive deficits that would clearly influence their ability to understand what you were spewing to them, or also how they would manage their now multiple medications when they go home. We implemented this in the COMPASS study, and since the COMPASS study, we have made an incredible digital AI platform in which we can integrate it into the electronic medical record. We can know what patients are coming in with a stroke. We queue them up for a 2-day call. We can then see them within 7 to 14 days, quickly interview the patient, find out what their social and functional deficits are. We can immediately generate a care plan, and we can provide a report. The providers know what the challenges are as they manage the patients. In collaboration with Carium, which is now owned by Health Map Solutions, we expanded this tremendously because 7 to 14-day visit is not sufficient. That stroke patients have chronic conditions. Stroke is a chronic condition. We found, and very well published in the literature, that when patients had a stroke, less than 50% of them have their blood pressure controlled after a stroke. We also now have the tremendous challenges with access to appropriate rehab care. As was documented in a 2024 congressional report looking at Medicare Advantage providers like United Healthcare, Aetna, Humana, is that the number one condition that they were denying post-acute rehab care for was stroke. And they had set algorithms to establish what would be in their best financial interest, and they were called out for this. We have established algorithms, right care, right time, based on the patient's clinical needs and their functional needs. Now, with Carium, we can engage with the patients, sending them surveys, by capturing remote monitoring with their blood pressure, their physical activity, their medication management, and we can use a platform to coach them about how well they're doing. And if needed to be, there could be a video interface to meet with them, a video person to meet with them, to manage them. So we're not simply a Epic care management. We are a patient-centered delivery of care. That is really important. And the other thing that's extremely important is that we can follow these patients. These patients are lost to follow-up, and we can follow them through this interaction and evaluate their 90-day outcomes. And we can adjust their program needs based on this ongoing communication. So it was with the Carium partnership that we now have the first comprehensive digital solution to care for patients. What we're also with other partners are looking at is how can we actually deliver the rehab interventions in the home? That is to be developed because everybody wants to go home, and certainly the insurance providers want you to go home, whether it's appropriate or not, but we can often provide some of the rehab interventions in the home. And I have worked on a clinical trial called the Imagine study, which we indeed developed a solution to interface with the patient, and we got incredible compliance. It's not just what we've done, it's what the future holds. By pulling together a comprehensive digital solution, we can interact with the patients, we can tone it down or tone it up, because many of these patients have so many problems, you can't address them all at one time. So you have to individualize it for the patients. What does this do for the patients? It improves their recovery. It gives them access to their provider. It decreases their level of disability. It can decrease the readmissions. This may not be politically correct, but it's not about readmissions, healthcare leaders. It's about the patient. And if you care for the patient, you will decrease the readmissions. We cannot do it with this episodic care. Get the patient out of the hospital, leave them with a parachute with a hole in it, and without ongoing management of the patients. Where we are is that it's difficult, however, to get health systems to embrace the new digital solution.
That's a great point. And there were a couple of things you mentioned, Pam, that really struck me. One was it's fascinating that you're extending this into home rehab. That is an area that, as we've been looking at our national data sets to see where utilization is, not only is there already a huge amount of home use in neurosciences, but we think that's going to be one of the fastest growing sites of care, home care, digital. With home especially, it's something that I know a lot of systems are concerned about as that center of gravity shifts away from our own sites of care, from the ones that we've traditionally managed. How on earth are we going to hold that connectivity? This sort of digitally enabled solution is going to be a way to ensure that connectivity. The other piece that I found really compelling is you've talked about the potential for this model to reduce, and what you've seen impact statistic of up to 40% reduction in readmissions for stroke, huge potential impacts. You also talked about the provider side and how well they've received it and how much easier it's made their lives. I'd be curious if you have any thoughts on that workforce augmentation angle. Can it extend the amount of patients that a navigator or providers can see? Is it just making their lives smoother and easier? What has been the benefit from the workforce side?
What we found is using this digitally enabled solutions can decrease the workforce 5 times because it depends on how you choose to apply it. You can interview patients before they come with a text, the surveys, get the information, and you immediately generate a care plan based on that individualized information. You can pull information from the electronic medical record into that as well. We have found tremendous reduction in staff required to comprehensively manage these patients. That is a big workforce solution. On the other hand, one of the challenges is there are not enough neurologists. And we quickly found that this is not the space that most neurologists want to be in. They're into the hyperacute management and acute care. So we are looking and have used, our whole model used advanced nurse practitioners, mostly nurse practitioners, but you certainly can use PAs. And they complement the neurology service and care. But even with that, there are ever-growing shortages of nurse practitioners to meet this, yes. But it does significantly reduce the workforce, and it can bring lots of revenue to the healthcare systems. We have been in the field. There is not a huge ROI. You get a larger ROI on bringing a patient to the hospital and doing a procedure than you do managing the patients over time. So the healthcare systems are all about what's the ROI. And even though we've demonstrated ROI in all of our work and presentations, it may not be their priority.
That was going to be my next question. It seems like the impacts are huge. So why isn't every health system doing it? Do you see that there are some organization types, given those misaligned incentives, that should be thinking more about providers who have health plans? Or what are your thoughts there?
From a humanistic perspective, if you bring a patient into your system, you should be careful to be able to manage them once they're discharged. And we see success in doing this with cancer, but a comprehensive stroke center, as certified by the American Heart Association, is not comprehensive post-acute care or chronic management. It's just the interventional radiologist on board. Yes, systems have been totally re-engineered from EMS to acute care to diverting patients to comprehensive stroke centers. We can do this, but there's a big ROI for that.
Thanks so much for sharing your story and the dynamics that health systems are trying to work within here to both personalize care, but do it at a scale and efficient way. We're faced that they're going to continue to be focused on ROI because, like you said, they don't have a lot of capital for new projects now. And there are many disease-specific point solutions, but it's great to hear some of the practical on-the-ground impact that it can make for patients and how systems really need to redefine their care pathways around that. Thanks so much for sharing that great story. And Kate, thanks for setting it up, how it's a problem today, but it's going to be a bigger problem in the future.
Everyone knows someone who's had a stroke, and everyone knows the struggles of being a caregiver of patients with strokes as well. We do need to continue this journey, and I'm more optimistic today than ever. I'm not optimistic about the healthcare systems as much as I'm optimistic about the potential to scale digital solutions and coaching to manage these patients more effectively.
Especially now in a time that feels very volatile and uncertain. This idea of keeping the end game in mind, creating effective patient-centered programs. There's no way we're going to be able to connect all of those dots in an analog environment. So certainly a great example of how that can really be effective.
Thank you, Kate. Thank you, Trevor.
Thank you for doing this. We really appreciate it.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at Sg2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, Sg2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You could find them at Vizient /podcasts. Have a great day.